Hello, I'm Dagny, Medical Director at Envision Eye Centers in Rowland Heights, California. And today I'm honored to be joined by Dr. Mitchell Weikert, Professor of Ophthalmology at the Colon Eye Institute at Baylor College of Medicine in Houston, Texas. Hi, Dr. Weikert, how are you?
I'm doing great, Dagny. How are you?
I'm good. Thank you for joining us this evening. So on this episode, we will be discussing advances in biometry as well as IOL calculations and platforms. So let's get right into it. So how are the advancements in biometry being used to help us remove cataracts correctly and achieve more accurate post-operative refractive error?
Well, I think we've all kind of enjoyed the advances that have happened in the last, 5 to 10 years. With the improved technology, we're able to measure more eyes optically. The devices aren't as limited on the grade of cataract as they used to be. And we're getting better at measuring the cornea. But when you look at the measurements we have to take, the different, axial lengths and other segments of the eye versus just measuring the cornea is still the most noisy part of all of our data. And it's great that we're getting better at that, but we still, despite the advances in technology, you really have to pay attention to the quality metrics that go along with these devices. And sometimes I think those get a little bit shortchanged on the day-to-day operations.
Yeah, we've definitely been able to improve accuracy and repeatability, mainly with those corneal measurements, as you mentioned. So I think some of the newer biometers, they measure a lot more points on the cornea than we did before. But another area that I think that we're improving to reduce post-operative refractive error is better estimating the effective lens position as well, which is often based on the corneal measurements. So it all kind of ties together.
Yeah, definitely. And I think when you go into this, I think it's a good idea to have a baseline idea of what are acceptable measurements. So these days, when you get an axial length measurement, they'll usually give you a standard deviation along with those. And we like to see those standard deviations plus or minus 20 microns or less, or 0.02 millimeters. And then for corneal power, we like to see the standard deviation for corneal measurements plus or minus about a quarter diopter. And so those are good to keep in mind. And that goes for the average K as well as the steep and flat. And then when you're looking at the axis of astigmatism, we like to see that plus or minus 3 to 4 degrees, about 3.5 degrees.
Awesome. Those are really nice thresholds to keep in mind to make sure that we are getting accurate measurements and the standard variability is actually as minimized as possible. What about for determining IOL power and how good are we getting now in terms of getting the IOL power accuracy down? I think Doug Hoke used to say our ceiling was probably 90% and we're not going to get much better than that. What are your thoughts?
Each year we're chipping away a little bit at that. And I think a lot of it depends on how meticulous, you are when you're doing your measurements. That's kind of obvious, I guess. But I think even the best of us are still hitting that 90% ceiling. I would say probably on average, we're probably in kind of the low 80s. And when you look at it realistically, we always wear those rose-colored glasses, so we often think we're doing better than we're at. So, which brings up the point, you should really periodically check your outcomes. And we found, I don't know if you use Veracity or another surgical planning software, but that's really helped us kind of keep track of our outcomes really in real time. So, if someone has access to that software, it's really a nice thing for kind of monitoring how well you're doing. But yeah, I think how we're doing also depends on what kind of eye it is. We're really good at average eyes, but we still are finding challenges on the long and short ends of the spectrum. We're probably a little bit better with long eyes than we are with short eyes. And so it'll come down to formula choice. And I think we're going to talk about formulas a little bit later on in this. But we probably these days tailor our formula to the different axial length category for the eyes that we're dealing with.
Yeah, absolutely. And I really want to round back on the point that you made earlier about keeping track of your outcomes. I think that's really important. No matter how good of a device you're using, right? There's still going to be intervariable factors that are going to affect your outcomes from one surgeon to another just based on what you do in the OR. And I actually do quite a few bilateral same-day cataract surgeries. And believe it or not, I've looked at my outcomes and it's close to 90%, which actually makes me feel comfortable about being able to continue to do bilateral same-day cataract surgery because we've just gotten, so much better than before.
That's actually a great point. And probably if you are heading in that direction, kind of monitoring outcomes even becomes more important, because when we talk about, what's the downside of bilateral same day or simultaneous or whatever surgery, it's, you can learn so much from the first eye and where that ends up refractively, that then you can apply that to the second eye. But if you're nailing it with the first eye, sure, go right ahead and do the second eye. So that's great. I'm impressed.
Yeah, it's great how far we've come with technology that we're able to do that more routinely. So let's talk about some of the newer devices that are out there that have allowed us to get more reliable biometric measurements. What are some of the biometers that you like to use or that you feel has really advanced the accuracy?
Well, when I think about biometers these days, I kind of divide the technologies up into two categories. One is kind of how they measure the segments of the eye, and then the other is how they measure the cornea. So I think when you're talking about how they measure the segments of the eye, they're all OCT, but there's typically the time domain OCT devices and then the swept source OCT devices. And then when we look at the cornea, there's the devices that use reflectance to measure the corneal power. And then there's devices that use imaging, like Scheimpflug OCT, to measure corneal power. So the time domain and reflectance are going to be your Iomaster 500, the grandfather of all of these. And then the lens star, they both are time domain and reflectance. When you're looking at time domain and imaging, then you're getting into the Pentacam AXL and the Galilei G6. They both use time domain OCT to measure the segments of the eye, but the Pentacam will use Scheimpflug, obviously, to image the cornea, and then the Galilei uses their combo Placido dual Scheimpflug to measure the cornea. And then now when we're getting into the newer OCT devices, swept source, we're going to have the Iomaster 700 and the Argos, which use swept source OCT to measure the segments, but then use reflectance still to measure the cornea. And then finally, the devices that use pure OCT for everything, segments and cornea, we're going to have the Anterion. And then we're going to also have, maybe down the road, the iStar, which is available in Europe but not quite available in the US. I think swept source OCT is kind of the newer OCT and has the advantage of it's a little bit faster. It's got a longer wavelength for the light source, so it's going to penetrate deeper into the eye, and it's got a little bit higher sensitivity. So that means we can measure more dense cataracts. We can measure, more advanced PSCs. So we can get more eyes with swept source. And swept source these days, if you look at the literature, can measure typically, 95 to 98% of eyes, and does really well with those really dense cataracts. And that's where kind of the time domain are going to fall short. Time domain are slower measurements, so you don't get quite the same resolution. The cornea is still up for grabs, as we talked about. That's the most noisy part of all of this. And, measuring with reflectance is going to have certain advantages. It's going to be sensitive to tear film. Well, they're all sensitive to tear film, but so you're going to have to deal with that. The devices that use either OCT or Scheimpflug to measure the cornea are going to give you a lot more data, but honestly, we're still trying to figure out what to do with that data. These days, some of these devices can measure the posterior cornea, which can, as we know, help us with our astigmatism measurements. But the question is, can they help us overall with our accuracy of measuring corneal power? And not to get into it too deeply, but a lot of them kind of massage the measurements that they get of the posterior cornea. And so, we're not really using pure data in any of these forms. A lot of these devices that have been coming around, like this Iomaster 700, like the Argos, et cetera, they all kind of massage their data to agree with devices that have come before. So they all try to match prior generations, which takes us all the way back to the Iomaster 500 and even back to ultrasound, because they're all kind of tuned to ultrasound. So that's kind of a limitation that we're dealing with. But
Oh my gosh, that was such a wonderful, comprehensive review of how far we've come in terms of biometry and the different modalities and technologies available. Certainly, I've seen it in my practice when I upgraded from the Iomaster 500 to the Argos. I think getting through those really dense cataracts was one of the most notable improvements I saw. So I routinely am able to get the axial length on an LP cataract, which previously I had to do, immersion A scan, for those cases. It's just remarkable that we're able to get through with some of the modern day biometers. And the benefit of the IOL Master 700, I feel, is the ability to measure the posterior cornea. And I think that one does so more accurately than some of the other devices. Like you mentioned, some of the imaging ones, the ShineFlow ones, the Pentacam, I think they can measure it as well. But it seems that a lot of the modern day formulas that take into account posterior cornea, they were designed actually with the biometers in mind and not actually with the imaging devices. So in terms of accuracy, I still think it's a little better to use it off of your IOL Master 700, your biometer. Do you use the 700? Do you frequently use the posterior corneas for regular cases, for IOL powers, or just complex eyes or for toric cases?
Great question. So it will give you the AK or the anterior keratometry, and then it'll give you the TK. We're always hearing the total keratometry. So in general, for typical eyes, we'll lean towards the AK measurements, but if we get for more toward kind of toric Iowa or toric cases, or really post-refractive cases, and then we'll lean towards incorporating that posterior corneal measurement into there. So we kind of use them both. I would say sometimes you'll see a disagreement between the TK and the AK. And for overall power measurements, we typically lean towards the AK because, again, that's what these formulas kind of were developed and tuned for.
Yeah, I agree with you. I've seen some studies, and I think, in the regular routine eye, it really doesn't make too much of a difference to use the TK, but definitely those complex, post-refractive cases, that's when you really see that difference, and the TK or the posterior corneal component really play a big role.
Yeah, and that the Barrett TrueK TK formula works very well. We just published a paper on that and have been kind of very pleased with it. Doug Koch won't like hearing this, but I used to, on every eye, even when we got the 700 with the TrueK TK, I would do both that and the Ascaris calculator and, try to plug in as many formulas as I can get off of that. But don't tell Doug, but these days I typically just rely on the Barrett TrueK TK that's integral or incorporated directly in IOLMaster 700.
Honestly, it's so good. I don't blame you. But I think the other nice thing is that we're moving towards convenience and being able to have all these diagnostics in one. And I think the Heidelberg Anterion is one form of that, where you're able to get high quality topographic readings as well as high quality biometry readings. I think some of the limitations that we have with some of the other devices, like the Pentacam AXL or the Galilei G6, like the corneal measurements are good, but the axial length is not always great. If the cataract's a little more dense, I don't know if you've had experience with any of those.
Yeah, we have both the Pentacam, we have the Galilei G6. And, again, going back to the time demand, I think, as you said, they're just a little bit more limited on the grade of cataract that they're able to measure. I'm looking forward to getting more experience with the Anterion. We've had it for 8 months, maybe a little bit longer. Yeah, and it gives really nice corneal images. They're very high resolution. It's a really long wavelength, about 1,300 nanometers. So it can really penetrate and can get a great measurement of kind of the entire anterior segment. It's probably a little bit higher resolution than Scheimpflug. So, as they, I think, learn how to deal with the data that they're getting and analyze that, I think hopefully things will just kind of continue to improve.
Yeah, my understanding is that one also penetrates a bit deeper than other OCTs. And so you can even image the sulcus anatomy, which typically we're only able to do with UBM to get good ICL sizing. I like to really optimize my ICL sizing using UBM, but I think in the future, we'll be able to use these next generation OCTs as well to get it better.
Yeah, I really hope so too. The iris has always been the limitation for optical measurements because it's so good at screening out, light. So hopefully these longer wavelengths might get us a little bit better view into the sulcus.
Wonderful. So let's round back a little bit to some of the things we were talking about earlier. You did mention that there's still some noise associated with biometry measurements, but the accuracy overall has gotten pretty good, where we could get pretty accurate IOL calculations. So what do you think are the main sources of error today, I guess, in addition to the cornea? And how are we improving our technology to better increase our accuracy?
That's always a great question. Sverker Norby, I don't know if you know him, but he did a paper several years ago now that was really great. He used ray tracing to look at the largest sources of error in IOL calculations. And he kind of used the typical standard deviations for devices and how they measure, and then incorporated that in the calculations to figure out what the impact was of all those different sources of error. And the number one, which I don't think surprises any of us, is effective lens position. Because basically we're trying to have a crystal ball to figure out where that lens is going to sit after surgery, not only immediately, but down the road as the capsule contracts and seals around that IOL. Where's that IOL going to end up, in its final position? And we both know that that doesn't occur, in the first day, in the first week, in the first month, in the first 3 months. It probably changes really long after the surgery, maybe up to a year or more. The second source of error was actually the manifest refraction. We're judging how well we're doing based on the postoperative refraction. And we all know the variability, not only in our own refractions, but in the different refractionists in our clinic, be it the physicians, be it technicians, be it optometrists, we're going to have varying quality of those refractions. And so by judging how well we're doing by that refraction, if it's a bad refraction, garbage in, garbage out, we're really not going to get a good estimation of how we're doing. And then in his study, the third source was axial length, but that was back in the days of ultrasound. These days with optical biometry, I think that's much better. So I think that third biggest source would go back to the cornea, and measuring the cornea. There have been a lot of studies out there, but if you look at measuring the same patient from week to week, you can see a very high variability in, the astigmatism, location, and magnitude, et cetera. So, there's going to be a lot of noise in that data. But so how are we doing in those sources of error? As I said, we're getting great on axial length, so that's kind of gone down the road. We talked about cornea. We're continually improving on that. And I think having a strategy to prepare your patient's cornea for surgery is key. I think these days, we're making sure that the patient's ocular surface is tuned up. We're very cognizant of looking for dry eye preoperatively. I'm sure you do. We put all our patients on a preoperative regimen to treat the ocular surface before we take them to the OR. So we're trying to deal with that. Manifest refraction, that's always a struggle, but for at least the study patients that we're doing, we have an optometrist that we kind of try to narrow down the number of people that are doing the refractions. Plus, technology-wise, we're getting access to maybe better technologies for measuring objective refractions. The Wavedyne is a new aberrometer out there. That it's still a Hartmann-Shack aberrometer, but it measures a lot more points within, the pupil, maybe several thousand points in a 7-millimeter pupil. So hopefully that will help us get more objective measurements. We still have to deal with that subjective part of the patient and where they prefer their vision to be. But I think we're going to be able to tackle that manifest refraction a lot better soon, which leaves us effective lens position. And I think we're about to transition into this, but probably the one area that's helping that is big data and artificial intelligence and better predicting the ELP.
Yeah, great segue there. I think you're right. ELP remains that kind of elusive variable that we still have trouble predicting. But as you mentioned, AI technology is helping on that front. So surprisingly, there are actually quite a few AI-based formulas that are already available to us today. Just to name a few, the EVO, Kane, Pearl, Hoffer QST, the Lotus Super 2.0, quite a few that are based, even Hill RBF, right, are based partly on AI. So why do you think these AI-based IOL formulas will be more predictive, and how do you think it'll continue to evolve over time?
When you think about the AI formulas, I like to group them there's ones that start off with a geometric-based optics formula, like the Binkhorst formula that is the same as the Holiday, the SRKT, the Barrett, the Hoffer Q, and then they use AI to improve upon those. So, AI is going to take a lot of data, thousands of patients. It's going to look at their refractions. It's going to look at all their biometry, and it can maybe identify hidden relationships between those. A lot of times we're not really doing a good job of considering this patient has a really deep AC and a really thin lens, or this patient has a really shallow AC and a thick lens, and how that variability bleeds into our calculations and our results. But when you got thousands of patients across, a whole broad range of axial lengths, you can start to do a better job of kind of refining the formulas, kind of training them. The one caveat that with that is when you're training calculators using AI, it's using the manifest refraction to do the training. So again, it circles back to really needing, the highest quality manifest refraction data that you can get, so you train the formulas accurately. But yeah, the EVO or the EVO, the Kane formula, the Pearl DGS, the Hoffer QST, they all start with the geometric optics-based formula. The Hill RBF just throws formulas out or the model out the window. So it doesn't really use a formula. It just uses the big data, the biometry measurements, and kind of trains the outcomes based on that. One thing we haven't mentioned is on Veracity, there's the AI formula that's in Veracity, and that started using ray tracing. So they kind of trained initially their calculator based on ray tracing. But again, ray tracing is great because it follows the rays through each refractive surface in the eye, but it still is guessing the effective lens position. So then they use postoperative data and biometry measurements to then train the system further that they started with the ray tracing. So, and that's shown promise too. But again, if you look at these formulas, under the best of circumstances, they're still kind of performing equivalent to each other and the Barrett universal too. So again, we're hitting the ceiling, but again, the AI stuff is kind of in its infancy, I think. So I'm hoping, fingers crossed, that as we get more data, we get more experience, these developers get better and better at looking at this stuff, that we're going to see better outcomes.
Yeah, I agree with you. It'll only get better with more data. I'm a Barrett 2 lover for sure, but I definitely see these AI-based formulas as sort of the future, especially for those complex eyes. We're going to be able to hopefully surpass that 90% ceiling. And I actually saw that wonderful study using the Veracity data. I think they had hundreds of thousands of data points. And from that, they were actually able to show better accuracy in short eyes, predicting the IOL power compared to any other formula. So I think that's definitely the future.
Yeah, we just published a study on that too, and found that formula, along with the Cook K6, did the best in the short eyes, but they were still sub 75% plus or minus diopter. So the short eyes, out of all the categories, are probably the toughest.
All right. So do you think, with all the formulas and new biometers that have been developed, that have been improving our accuracy, do you think some of the newer generation IOL platforms have helped us in some ways to sort of nail that refractive outcome, perhaps because some might be a little bit more forgiving or have a larger landing zone? Or what do you think about some of the newer IOL platforms and how it might be helping us surgeons, hit that target that we want for our patients?
Yeah, that's a great point about the landing zone. I think both some are a little bit more forgiving, but some have really made us have to up our game with the biometry too. So, when we look at those, we've got our enhanced monofocal IOLs, we've got our EDOFs, our extended depth of focus IOLs, and then we have our trifocal IOLs. So they all kind of have their unique challenges and their unique roles. The enhanced monofocals, like the iHance, and what's the new one from
Aspire.
Yeah, the Aspire.
Also, the Ray 1 EMV is another one. So that category is growing. Yeah.
Yes, it is. That's exciting too. And honestly, the light adjustable lens has it's not a direct EDOF, but it's got some EDOF-like behavior in it. So, these, if you look at the defocus curves, they're a little bit broader in their drop off as they start to lose vision as you get away from kind of your really emmetropic distance. So they are a little bit more forgiving with that. So you could end up, a little bit hyperopic, a little bit myopic, but still be kind of okay. We found that when we kind of nail the distance with an enhanced monofocal, that we get a little bit better intermediate vision. So I don't mention that to any patients. It's just kind of that nice postoperative result or outcome. So I would be very careful. I wouldn't recommend promising patients they're going to be able to read intermediate with an enhanced monofocal. It's just kind of a nice surprise, a little extra fringe benefit.
And it's a nice surprise for the surgeon when you accidentally fall a little bit more on the myopic side, but hey, the patient gets more of that intermediate increased range. All right, so wonderful. I think we covered everything on this topic, from how we've improved in our accuracy and nailing our targets. So thank you so much, Dr. Weikert, for this excellent discussion. Thank you all for listening. Please remember to take the post-test and evaluation to receive CME credit and tune in for additional episodes within the podcast series. Thank you, everyone.